And a very good evening. My name is Rob Timmings from ECT for Health, and you are joining us for the first of our 9 to 10 part series on the trauma foundations. This particular session tonight is really an introductory session. We're going to be having a look at a little bit of the kinematics of trauma. We're going to be looking at the biomechanics, what trauma actually is, and we're going to take a bit of a deep dive down into some cellular biology and have a look at that first sort of platinum 10 minutes through to the golden hour, where we see our peaks in trauma death. For this very first session, it's important for everybody who is live to know that my preference would be that you keep your microphones on mute unless you specifically have a question, in which case everybody is very, very welcome to ask questions. And if you're not here live and you're watching the video as part of a participant in the video series that you've purchased, then we are also open to you asking questions via email. And you just simply need to contact me via email on the email address that's been sent through to you. So without any further mucking around, let's get started on our trauma foundations or trauma care foundations. So trauma as defined is quite literally injury to tissue. So in the context of this particular series, we're doing tissue trauma. We're not talking about emotional trauma or distress or psychological trauma. Childhood trauma, family trauma. We're talking about physical trauma to body systems. So where trauma is injury to tissue, the injury to tissue has occurred as a result of an energy transfer. And so fundamentally, when we talk about energy transfer, we would say that that part of the body that had a transmission of energy, where energy was the vector, has been unable to withstand that energy, and an injury has occurred as a result. We're going to go into a little bit more detail in that a little bit later on. But taking a bit of a snapshot at our trauma stats as we see them in Australia, we see around about 13,000 trauma deaths annually. There's a 400% increase in trauma death if we are more than 100 kilometres from a major metropolitan trauma centre. And that would be defined as a trauma centre that has all the capabilities of doing emergency trauma surgery, damage control surgery, and neurosurgery. The leading cause of traumatic death in those under the age of 45 is suicide, followed by transport injuries. And in those over the age of 45, the leading cause of death is actually falls. When we have a look at deaths from trauma, of course, not everybody dies from trauma. You might cut yourself in the kitchen when you're doing some cooking. That's, of course, a trauma. That didn't kill you. But for those that have succumbed to their traumatic injury, approximately 80% of those who will die from their trauma will die within the first 4 hours. The other 20% of people who will die from their trauma, they die usually at that 2 to 5 day mark. And then again, there's another peak at the 2 to 3 week mark. So we can roughly say if the trauma doesn't kill you within the first 4 hours, but it's going to kill you, it's more likely to take your life at about the 2 to 3 days or at the 2 to 3 week mark. And we would refer to those two as the third peak of death, where the first peak of death is immediate. The second peak of death is that magic golden hour that we talk about, which is actually the 4 hours that we're talking about. And the third peak of death are those delayed deaths that we see in intensive care or in the ward or in the recovery unit at that 3 to 5 days or that 3 to 5 week. There seems to be a bit of a dichrotic peak there. Trauma is expensive. It's probably one of the most expensive health dollar spends within our health industry. It absolutely dwarfs the cost of type 2 diabetes. It dwarfs the cost of cardiovascular disease. And of course, in many regards or many respects, trauma can be somewhat preventable. Now, there's a little bit of a trigger warning, I suppose, here with this session. Of course, we're going to be spending 9 weeks together talking about trauma. So there, of course, is going to be some pictures that may not be the sort of pictures that you'd like to show or have on easy display in a public area or in an area where you have family, friends who are not medical, and indeed children. So I'd like you to use your discretion when you're viewing these videos or when you're participating in these webinars, just to make sure that whoever is able to look over your shoulder and looking at your computer, um, uh, this is just a fair warning to you that some of the images may be very confronting and quite distressing to those for whom they never signed up to see this sort of stuff. So just to please demonstrate some discretion in that regard. Likewise, some of the commentary that you're listening to out loud, my preference would be that if you're listening to this as a live webinar, that you're in a private space, that you're able to that my voice and our questions isn't going to sort of move away from the space where you're participating. And if you're actually viewing this as a recording, then again you would be listening to it maybe with some headphones or some earbuds or something similar. So in this first session, we're going to have a look at the cell under threat. We're going to do a little bit of a dive into the scientific basis. We'll have a look at geographical considerations, the pre-hospital role, and certainly we're going to have a look at a multidisciplinary approach. But what is trauma really all about when we're talking about life threat? And ultimately, if we can synthesize trauma death in the immediate short term, it's ultimately to do with a loss of airway, a loss of breathing function, a loss of circulation, usually through blood loss, and a loss of consciousness. In the short term, first 4 hours, what kills our patient is a loss of their airway, breathing, their circulation, and their level of consciousness. Blood loss has to be the biggest key feature when we're having a look at the physiology or the pathophysiology of trauma. And that's blood loss that's passed. So how much blood has the patient lost to the point of now arriving in your care? So if you're working in a pre-hospital environment, how much blood has the patient lost before you and your crew and the truck got there? How much blood has the patient lost during your care? And how much blood will the patient go on to lose after your care has finished and the patient's now been dispatched essentially to the next port of call with respect to their ongoing trauma management? So for me as an emergency nurse, of course, I'm going to be receiving a patient who's lost some blood. They're going to lose some blood while they're in my care. And of course, I'm now going to send them usually through to theatre or intensive care. But if it's going through to the operating theatre for damage control surgery, then it makes absolute sense that they're going to also continue to lose blood. And all of those things act and have a key part of the mortality and the ongoing morbidity of a patient who is experiencing trauma. So let's do a little bit of cell biology. Ultimately, when we're worrying about our life threats, we're worrying about airway, breathing, circulation, and disability. And fundamentally, this all comes back to an inability for cells to function. So pull out a piece of paper, pause the video if you're watching this as a video, but pull out a piece of paper and a pen, and we're going to do a little bit of a whiteboard exercise. First things first, I'm trying to find a color that we can all see. This is the first thing I'm going to do. So let's go with this dark blue color. We should be able to see this image. Now, this is an image that's going to represent a cell in your body. And ultimately, all cells are going to require fuel to burn to produce energy. And you would have learned about those 3 things back in your undergrad, maybe even back in high school. You learned about glycolysis, which is the breaking down of glucose, and glucose is our cell fuel. You learned about the Krebs cycle, and you learned about oxidative phosphorylation. Oxidative phosphorylation. So these are the 3 steps in the energy cycle for all cells in your body. So Glucose is the first step. It has to be first broken down. And this process of breaking down glucose is called glycolysis. When we undergo glycolysis, this does not require oxygen. So this is an anaerobic step. So it's a non-oxygen requiring pathway. Just bear with me. I'm going to admit somebody who's sitting in the waiting room. Okay. Alrighty. So glucose comes in. And what happens when glucose comes into a cell? It undergoes glycolysis. Enzymes within that cell are going to split that glucose molecule and ultimately turn that glucose molecule into an acidic molecule called pyruvic acid, pyruvate. Just waiting for this word to come up. It's just happened. Bear with me. Pyruvate. Now, looking at this word, if you see that this pyruvate ends in ATE, and this is something that we see quite a lot in biochemistry and a lot in pharmacology. If a word ends in ATE, it generally means acid. So pyruvic acid is pyruvate, which would mean if I said the term lactate, that's considered to be lactic acid. Folate, that would be folic acid, and the list goes on and on and on. Now, what we're going to do in cellular fuel, when we fuel a cell with glucose, is we're going to break the glucose down into two pyruvate molecules. And it's those two pyruvate molecules with the addition of oxygen that then undergoes these next two chemical pathways. The first of them is the Krebs cycle to produce about 4 energy units, and the energy units are referred to as ATP, adenosine triphosphate. So glucose goes in, the Krebs cycle, it splits into pyruvic acid. That pyruvic acid then enters into the mitochondria of your cells, the powerhouse of your cells, and in the presence of oxygen, undergoes the Krebs cycle or the tricarboxylic acid cycle and oxidative phosphorylation to produce a yield of approximately 32 ATP. So think of these ATPs as energy. In short, for every 1 glucose that I produce that goes through this oxygen-dependent system, I'm going to produce 32 energies. And if my cell can make 32 of energy, if it can make this ATP in this quantity, then my cell can function. So if we're talking about somebody's cardiac tissue, cardiac cells can contract if they're making enough ATP. Brain cells can make neurotransmitters and transmit their messages if they're making enough ATP. White blood cells can kill bacteria if they're making enough ATP. Blood vessels can auto-regulate as far as their volume if they're making enough ATP. Can you see that it doesn't matter what organ or what tissue we're talking about in the body? If oxygen is present and fuel is present, in an otherwise non-damaged cell, then that cell is capable of making enough ATP so that it can do its work. Now, when we drill back to, well, what's the real problem when somebody has major trauma, large blood loss trauma? It's the loss of capacity to be able to deliver oxygen to tissues. So a patient who's had a large femoral fracture or a big exsanguinating wound from an abdominal trauma or a chest injury or a pelvic fracture, where they've lost a very large volume of blood, they've physically lost their capacity to be able to deliver oxygen to all other cells in the body. What started out to be maybe a pelvic injury has now become an all-of-body catastrophe when it comes to the capacity to be able to deliver enough oxygen to tissues to be able to make enough ATP. Now, in the absence of oxygen, in cells that are hypoxic, they are unable to make this sort of ATP. They can only make 2, and that's not enough energy for cells to be able to do their work. So you'll see cardiac tissue will shut down. Person's inotropic function of their heart, their physical capacity to be able to pump, is going to be reduced. You'll see cerebral tissue shutting down. They will have an altered level of consciousness. You'll see renal tissue shutting down. They're going to start to drop off urine output. So you can see that if everything comes back to this concept that we've got a syndrome here, trauma is a syndrome that's going to ultimately lead to a state of hypoxia in my patient, then the consequence of that is we're going to start to see all cells in the body are going to demonstrate a lack of ATP production and therefore a lack of function. It's fair and reasonable, therefore, if somebody's lost half of their blood volume, that you would expect them to be altered in their level of consciousness, to have tachycardia, to have a really poor cardiac output, to have a respiratory rate that's elevated, to have renal function that's obliterated, to have next to no hepatic function, to have gut that's completely stopped in its peristalsis. Every tissue needs ATP to be able to do its work. And it can't make that ATP from glucose unless it has oxygen present. So let's take it a step further and have a look at, well, what is the consequence then? Other than the fact that I'm not making ATP, what's that consequence of not having enough oxygen in this process after glycolysis has taken place? I'm just going to get rid of some of this visual pollution on the screen for a moment. Okay. So we've talked about as glucose comes in, oxygen comes in. Pyruvic acid, two of them, enter the mitochondria and produce 32 ATP. Ultimately, that's the simplification of what we've just said. This is an oxygen-dependent or an aerobic-dependent process, and in the absence of oxygen being delivered to tissues as a result of blood loss or shock, then the pyruvic acid cannot enter the mitochondria and it can't become that ATP. So what this pyruvic acid starts to do is it starts to convert into lactate or lactic acid, lactate. And as it starts to convert into lactate, it accumulates on the inside of every cell in your body that is in a state of hypoxia. So all cells that are lacking oxygen, all cells that are experiencing this hypoxia, start to convert their pyruvic acid, not to ATP because that needs oxygen, but it ferments it into lactate. Now, in fairly close proximity to every cell in your body, you're going to have a blood vessel. Remember, all of your tissues are being perfused by a fairly healthy vascular supply. And we know if we were to have a look at somebody's lactate level in their blood, measure the lactate that's inside your blood right now, that it is measurable. Right now, if I took a sample of your blood, I would see that your lactate level in your blood sits at around about 0.5 to 2 millimoles. And that's per litre of blood. Now, you've only got 5.5 litres of blood. So at most, I would ever expect to see in your blood would be maybe 10 millimoles. But that's even considered excessive. It's often less than 5 in your whole body. Now, this is in your bloodstream. Now, if I had a patient, therefore, that was in this state of hypoxia and globally no tissue was getting enough oxygen, let's say because they've had a large blood loss, my trauma patient as an example, remember every cell is starting to produce this lactate. And as this lactate starts to become abundant on the inside of every cell, that lactate diffuses out of the cell and into the interstitial fluid, what is essentially referred to as the interstitium or the third space or the extracellular fluid. Now, as lactate levels start to rise outside the cell, but also equally outside of the blood vessel, you can see that you've got a huge increasing concentration of lactic acid molecules outside of the bloodstream and a relatively low concentration of lactic acid molecules on the inside of the bloodstream. And the process of natural diffusion is going to take place through the capillary membrane, which is semi-permeable. And that lactate will ooze, will diffuse is the correct term, will start to diffuse into the bloodstream. So now we're getting an accumulation in this patient that's profoundly hypoxic because of blood loss. And let's just give that a name. Let's call that for the minute, call it shock. So the patient's gone into shock. What's happening? Well, they're pouring lactate into their bloodstream. Now, as they're pouring lactate into their bloodstream from this accumulation of lactate in their hypoxic tissues, that naturally is going to place this lactate level up. Now, if lactate is lactic acid, it stands to reason that the more lactate that goes into the person's bloodstream, the more acidic their bloodstream will become. So we start to see a drop in pH. So the consequence of severe hypoxia and poor perfusion of tissue with oxygen is always going to be a drop in pH or acidosis. So acidosis becomes our complication with these patients. And it's for this reason in all of our sick patients, from the septic patient through to the hypovolemic blood loss patient, through to the cardiogenic shocked heart patient, all of these patients, we're always going to be measuring lactate levels on these patients to give us a bit of a measure as to how deep their shock has become. It's one of our markers to indicate how anaerobic their glucose metabolism has become as a result of poor oxygenation. Now, at any time, I know this is complicated stuff, but at any time, you're more than welcome to pop on your microphone and clarify or ask any questions. I'll just keep on rolling unless you interrupt me. Okay. So how does the oxygen get to cells? Well, it gets to cells with this guy. We're going to call him the red blood cell. Remember, your red blood cells are essentially just a delivery truck. But I want you to imagine that this delivery truck, if you could go to the back of the doors of this delivery truck and you could open up the big back doors of this delivery truck, on the inside of this delivery truck, you're going to see 300 million little boxes that are holding the oxygen. Every red blood cell contains approximately 250 to 300 million molecules of a substance called hemoglobin, or HB. And HB is kind of best drawn structurally as hemoglobin inside of a box with four little receptors, four little arms. And each one of these arms is capable of binding with a single diatomic oxygen molecule. Remember, oxygen is an element by itself, O1, or just O, oxygen, but it's paired with and it's partnered with another oxygen molecule to make it the very familiar to us O2. This is referred to as a diatomic state, and oxygen exists in a diatomic state, a stable diatomic state, when we transport it within our blood on the hemoglobin molecule itself. Now, remember, we've got about 300 million of these hemoglobin molecules in every single one red blood cell, and you've probably got about 50 trillion red blood cells. So that's a lot, right? That's a lot. Now, each hemoglobin molecule is capable of holding 1, 2, 3, 4 molecules of oxygen. And when this hemoglobin is holding 4 molecules of diatomic oxygen, this hemoglobin cannot carry any more oxygen. This hemoglobin molecule is said to be saturated. So when we take a patient's SATs, we put a SATs probe on their finger and we're measuring the saturation of a patient, we say, oh, they're 98% saturated, or their oxygen saturations are 88%. This is exactly what we're looking at. We're looking at the hemoglobin itself. We're looking at how well bound to hemoglobin are these molecules of oxygen. And if all of your hemoglobin is holding 4 molecules of oxygen each, then we would say that you are 100% saturated. And this is the sort of the landmark state, the benchmark state of blood in your arterial blood supply. So when blood has left the lung and it's making its way now via the pulmonary venous network back to the left heart to be pumped out of the aorta and around your body in a fully oxygenated state, that arterial blood is said to be at or around 100% saturated. When it's returning back to your right heart, so back to your right heart and then gets pumped into the lungs as deoxygenated blood, that venous blood is said to be approximately 75% saturated. So when we're looking at arterial saturations, sure, we're expecting somewhere around 100%. If we're looking at saturations on a venous blood gas sample, then we're looking at around 75% sats would be considered to be normal. But we don't. When we stick a finger probe on somebody's finger and we're looking at their oxygen saturations, their saturation of pulsatile oxygen, or their SpO2, then what we're getting is something, we're expecting something that's going to be north of 90. So north of 90%. And many of you would have learned that you want it sort of above 94. And we've sort of changed that dogma a little bit over the last 5 years. We've started to come down and recognize that really somebody's saturations, providing they're above 90, then they're providing enough oxygenation to their tissues. Yeah. There are certain populations, of course, and I know we're stepping a little bit away from trauma here, but there are certain populations, and of course we understand our COPD patients. They will often have saturations that are sitting at around about that 88 to 92%, and that's considered to be their normal range. But remember, we're not talking about an abnormal population here. We're talking about what is a normal population saturation expected to be on a well-perfused finger. Well, it's going to be around about north of 90%. So most jurisdictions will say that if your patient is saturating below 90%, we should be putting oxygen on to supplementally bring their oxygenation back up above that 90. Hemoglobin can only be 100% saturated. So if your patient is already saturating, certainly above that kind of 96% mark, they don't need oxygen. They don't need it now. They don't need it when they're in trauma. They don't need it when they're having chest pain. They don't need oxygen. No one needs oxygen if they're adequately saturated. Think about what that word means. Saturated means full, can't get wetter, right? If you were naked in a swimming pool and I sprayed you with a hose, you're not getting any wetter. You're saturated. And hemoglobin's the same. Stop thinking that we need to put oxygen on any patient that has adequately normalized saturations. There isn't a role for it. And indeed, in certain types of trauma, particularly cardiac injury and cerebral trauma, too much oxygen actually causes them harm. And this is a really interesting concept. Okay. So our fundamental priorities in trauma, therefore, recognizing that ultimately our trauma is all about maintaining that patient or preventing the life threats, is of course to maintain a patent airway. It's to oxygenate and provide with assistance to ventilation if the patient requires it, and provide oxygen only when the patient needs it. In other words, when they're not saturated, we can try and saturate them. To stop bleeding, and that may include damage control, and then to support perfusion by replacing blood products or blood loss. Our focus in that very first 4 hours is really airway, breathing, circulation. That's our primary focus. And we're going to get into in our next session whether airway really is our highest priority. That's changed over the years. Whether circulation's our highest priority, whether breathing is our highest priority. We're going to have that conversation in our next session. And then after we have looked at our first and second peak deaths, we also need to be really vigilant for these life threats that go on to take our patients' lives at the 2 to 3 day mark and at the 2 to 3 week mark. And these, I'm going to be referring to these as the dark horses. Of course, the dark horses have been well known in the past as what was called the trauma triad or the trauma triad. They were the 3 elements of a patient who becomes acidotic, patient who becomes hypothermic, and a patient who becomes coagulopathic. But over the last 3 to 5 years, there's been an emergence of a 4th player within this trio of death, And now we have what we have now is referred to as the diamond of death. Instead of the trauma triad, then we have the diamond of death, and this includes hypocalcemia. So let's break these down and just understand where they sit. First and foremost, we've already discussed acidosis, this first life threat of acidosis. Patient who's lost a lot of blood is a patient who is poorly perfused. Patient who's poorly perfused is a patient who is not oxygenating tissue. And as they're not oxygenating tissue, that anaerobic production of lactic acid starts to accumulate. Microvascular blood vessels start to occlude. And when these tiny little blood vessels on the inside of our vital organs, like heart, lungs, brains, and kidneys, start to clog up and become inflamed, then it stands to reason that we're going to start to have occlusion of oxygenation to those vital organs and an accumulation of lactic acid. Now, we're looking at this slide here that talks about acidosis. And acidosis can be measured both in a venous blood gas sample and an arterial blood gas sample. And the values are ever so slightly different. So if we're looking at somebody's VBGs, venous blood gases, and this is, I just want to alert you to the asterisk next to this 7.31. The VBG normal pH is 7.31 to 7.41. That's the normal pH range if I was taking that blood sample and putting it through a venous gas analyzer from somebody's vein. So let's say that blood was taken at the same time their IV cannula had been inserted, and that sample of blood was sent off to the lab or to the ISTAT, and we were measuring their venous blood gas sample. pH we're expecting is 7.31 to 7.41. Arterial blood is ever so slightly more alkaline, and it's more alkaline because the carbon dioxide that's in venous blood in abundance tends to have an acidic influence. More carbon dioxide that's in blood, the more acidic blood becomes. That rise in CO2 tends to shift the pH ever so slightly down. And this is why venous blood is ever so slightly more acidic than arterial blood. Now, arterial blood's normal range is 7.35 to 7.45. So it's ever so slightly shifted off to that right-hand side. So with hypoperfusion being the main feature in our shocked trauma patient, then we see that lactate level rise. With a normal lactate, some reporting a normal lactate of 0.5 to 1 millimole per litre. Later research suggests that up to 2 millimoles is probably okay as well. Then certainly an early lactate rise in somebody who's lost a lot of blood is very much one of the indicators that we would be looking for in an acidotic presentation, a patient who becomes acidotic. In previous years, we have been very aggressive with our fluid resuscitation. Just 10 years ago, it was completely normal to put 2 large bore cannula in all of our trauma patients, stick up 2 liters of normal saline and start running those fluids in before we could even blink, before we could even load the patient in the ambulance, or before we even called the registrar to come down and assess the patient. We were bang, bang, bang with our assessment process, and very, very early on, we were putting in large bore cannula and running 2 liters of warm normal saline. And there are nurses and paramedics that are going to be watching this that remember the old days of TNCC teaching and PHTLS teaching and EMST teaching, these programs where we had to aggressively fluid resuscitate. Well, now that's a thing of the past. We don't aggressively fluid resuscitate anymore because we now understand that this causes a massive chloride shift. When I give you a really large dose, a litre or 2 very quickly of normal saline, then the chlorine that's in that sodium chloride, the chloride will shift away from the sodium and combine with hydrogen ions that are in your blood and form literally hydrochloric acid in the blood. A person starts to develop hyperchloremic acidosis as a result of this chloride shift. So it's for this reason that when we do fluid resuscitate, early fluid resuscitation of our blood loss trauma patient, we're really just looking at a permissive hypotensive model where we only want to give enough fluid in small boluses, aliquots of say 100 to 200 mils, no more than 500 mils in a bolus, just to prop their blood pressure up so that their blood pressure is hovering with the mean arterial pressure of around about that 60 to 65. We don't want to get that systolic blood pressure above 90. We're targeting this patient to target hypotension with our fluid resuscitation. Certainly, we're trying to stop bleeding, but when it comes to the fluid resuscitation, it makes absolute sense that if the patient's lost blood, they need replacement with blood, not salty water. And we've made those mistakes too often in the past. So a permissive hypotension model is something that I'm going to go into in more detail in session number 3 when we do our shock session. Now, as we fluid resuscitated patients in the past, we also caused them to become cold. It's very difficult to take IV fluids and rapidly infuse them into a patient unless we've got very specific rapid fluid infusers that warm the fluids in real time. Remember, we've got a human being that's supposed to be lying on this table at 37 degrees Celsius. And in many respects, we were pulling fluids straight out of our ambulance or straight off the shelf in our emergency departments with those fluids sitting at about 25, 24, 23 degrees. And in colder climates, even cooler. So by rapidly fluid resuscitating our patients with large volumes of normal saline or Hartmann's that were not kept at body temperature, they were at room temperature essentially, we were rapidly cooling our patients and then we were placing them into a state of hypothermia. So the big question is, how do I know my patient is acidotic if I can't take a blood sample? There's going to be pre-hospital personnel and paramedics and military medics that are following this series. How do you know on the battlefield, or how do you know in the back of your truck, or how do you know on the side of the road that your patient's acidotic if you're not measuring their VBGs or their ABGs? And the simple answer to that is a respiratory rate. The most powerful tool that you have in your observational skill set, particularly with your shocked trauma patient that is potentially going into acidosis, is going to be a rise in respiratory rate. So recognizing that a patient has a respiratory rate normally at rest, an adult normal respiratory rate range sits between 12 to 16, and we allow up to 20 breaths per minute when we count their respirations. Anyone that is above that 20 breaths per minute sitting at rest is either anxious or acidotic. They're one or the other, perhaps both. Please always assume the worst. Please always assume that it's acidosis first, particularly in the context of somebody who's lost a large amount of blood. And there's a fundamental reason for this, and that is where once upon a time we believed that your stimulus for breathing was an elevating or a rising carbon dioxide level in your blood. We now don't believe that to be the case. That elevation of CO2 is not your primary stimulus that triggers your breathing rate. It's the pH. So within the respiratory center of the brain and the pons and the medulla oblongata of your brain, where you've got these chemoreceptors that measure things like oxygen and carbon dioxide, there are chemoreceptors that are also sampling the pH of cerebrospinal fluid, your CSF. And this correlates very closely to the pH of blood. And as your blood pH drops into acidosis, the respiratory center says, way too much acid, pH is too low, way too much acid. We will stimulate the lungs to breathe faster and deeper to blow off any excess acid that we might be able to excrete. And of course, the excess acid that the brain is instructing your lungs to blow off by increasing your respiratory rate is carbon dioxide. So you can see that we certainly have a seesaw relationship. I'm going to try and bring this little pen into play here. We've got a seesaw relationship between pH and CO2. We know that. If I could draw this little sort of a seesaw here on the slide, where we've got a person's pH on this side and the person's carbon dioxide levels in their blood on this side. The belief was once upon a time that a rise in CO2 was the trigger for breathing, We now believe that it's not a rise in CO2 that triggers your breathing, it's the other end of the seesaw. It's a drop in pH. And irrespective of what your carbon dioxide's doing, anything that causes you to have a drop in pH, and we've just had a whole conversation around lactic acid, and we've had a whole conversation around hypochloremic acidosis. And for anyone that's working in emergency services that has cared for a patient with ketoacidosis, the diabetic ketoacidosis, how are they breathing? They've got Kussmaul's deep, rapid breathing. Do you see that this is a respiratory neurological effect caused by acidosis? So every patient who's acidotic will breathe deeper and faster in an attempt to blow off the only acid that they can get rid of out of their blood, which is carbon dioxide. It's a compensation. They're not breathing fast because they're breathless. They're breathing fast because they're acidotic. So with hypothermia, there's two really key factors when we talk about the hypothermic patient. First of all, we're losing blood. Let's say we're lying on the road, we've had a big trauma, and we're losing blood. What we're doing is we're losing blood at a temperature of 37 degrees. So we're physically losing heat. We're bleeding heat. And we're in a cold environment. The back of your ambulance, the emergency department, the back of a tent, in a medical aid post. These are not kept at 37 degrees. God, I hope you don't have to work in a place that's kept at 37 degrees Celsius. We work in a nice, comfortable, usually air-conditioned environment that's somewhere in the 20s. And the sicker our patient becomes, the more shocked our patient becomes, the less their own thermoregulation is able to modify their body heat. And these patients can quite literally, like a lizard or a snake, become poikilothermic and start to reduce their body temperature to that of their surroundings. Can you see that cold trolley that they're lying on can actually make the patient go into a state of hypothermia? So these drops in temperatures hinder cellular metabolism. When cells slow down, when cells have a reduction in temperature, then their metabolic processes also decrease. They decrease their capacity to make ATP. So even when oxygen is restored, cold cells just don't make enough energy for those cells to be able to function well. Cardiac tissue becomes very resistant to electrical and medication therapies. So if your patient goes into VT or VF, being able to successfully shock a cold patient back to a perfusing rhythm is a lot more difficult when their temperature starts to drop down below 34 degrees. Vasoconstriction and shivering increase that acidosis dramatically and increase oxygen demand. Remember, for a muscle to be able to wriggle or to shiver to generate heat, it burns a massive amount of oxygen to be able to do that. And this is something that in a state of shock, our bleeding trauma patient just doesn't have an abundance of. They don't have the oxygen to satisfy the increase in oxygen demand when they're cold. And then, of course, the other big element there is the fluid resuscitation with cold fluids. It doesn't matter whether you're giving 100 ml bolus to your trauma patient or whether you're giving 1,000 ml bolus to your trauma patient, but for the love of God, will you warm it up? Make sure that it's being taken out of a blood warming device or a fluid warming device, or that you've got some sort of a way in your facility that you can get that bag of saline or that bag of Hartmann's up to and as close to body temperature as possible before we start to infuse it, because it dramatically reduces the temperature of a patient. Just 1 litre poured into your 5 litres of 37 degrees Celsius blood can have a dramatic effect at dropping your body temperature. In burns, when we lose large amounts of skin, a large total body surface area of skin loss causes a massive amount of heat loss and a massive amount of a decrease in capacity to be able to shiver and generate heat. Medications like muscle relaxants that we routinely use when we're paralyzing a patient so that we can intubate them or take them to theatre, that reduces their capacity to be able to shiver. They can't maintain normal thermogenesis or normal creation of heat under the influence of those muscle relaxant medications like rocuronium and cisaquarium, and the list goes on. When patients have high spinal cord injuries, particularly above the level of T6, so mid-thoracic, T6, roughly between your shoulder blades and up. Complete severance of the spine can render the patient into a state of neurogenic shock. And we're going to go into these shock syndromes in a little bit more detail when we do our shock session in episode 4. But with our neurogenic shock patient, they become literally poikilothermic. There is no neurological feedback from their body to tell their brain that their body's getting cold. So the brain then doesn't manage autoregulation. The hypothalamus that sets your thermostat in your body, that little organ in your brain called the hypothalamus is your thermostat. It fails when somebody has a severe neurological injury above the level of T6. The patient is rendered what is referred to as poikilothermic. And if that's not going to be your word of the week, I don't know what is. It's one of the coolest words in medicine. Poikilothermia is think lizard or think snake, right? To be able to warm up, it has to go and lie in the sun on a nice warm rock. It's a cold-blooded animal that uses an external environment to maintain its body heat. It's not warm-blooded like humans, mammals, birds are warm-blooded. Poikilothermia occurs when somebody has a severe spinal cord injury above the level of T6. We'll do a bit more on that in a couple of episodes. Now we move into the third of our triad, which is coagulopathy. When people have a large amount of blood loss, they're losing a large amount of their coagulation factors. Remember, there's two things going on. As you bleed, you're trying to stop your own bleeding. You're trying to clot, you're trying to coagulate. And when you're trying to clot and coagulate, you're consuming your platelets. You're consuming your factor 8, your factor 9, your factor 10, your fibrinogen, your prothrombin, all of those coagulation factors that are made in the liver but circulating in your blood in normal concentrations right now, they're lost when you bleed them out on the road. When that patient has had a large blood loss trauma, they've not just lost those coagulation factors, those clotting factors, but they've also started to consume some of them. They're using what little clotting factors they've got left in their blood to try and stop their bleeding. So now we have this patient who may have lost 3 liters of blood. They've been scooped up and brought to us by the ambulance service. They've been taken into an emergency department. They've essentially lost half of their blood volume, or a little more than half of their blood volume, which by definition means they've lost half of their coagulation proteins. And then because they're profoundly hypotensive, they've dropped their blood pressure into their boots, right? They've lost half their blood volume. They've got a blood pressure that looks like, I don't know, 70 on ugly. We're going to fluid resuscitate these patients. We're going to try and bring their blood pressure up a little bit. But what we've done is we've poured fluid into this patient and further diluted what little coagulation factors and platelets they had left. Yeah. So we've taken this patient that had 3 liters of blood. We've poured 1 liter or 2 of normal saline into them, or Hartmann's into them. We might have brought their blood pressure back up. We might have brought their volume back up, but we've essentially, I don't know, poured more Coke into the rum and Coke, right? It's not the same drink anymore. It's not the same concentration of coagulation factors. We have dilutionally made them coagulopathic. So those two concepts are key players here. So trauma-induced coagulopathy happens through 2 mechanisms. One is consumptive. They're consuming or have lost their coagulation factors because they've either bled them or they've engaged in the process of clotting. And our fluid resuscitation has diluted their coagulation factors in the same way that topping up your glass of rum and Coke with just Coke changes the composition of the balance. So let's build a clot. How do you make a clot? How do you stop bleeding? How does our body, once injured, stop bleeding? And this whole process is referred to as hemostasis. Let's jot that down. So hemostasis quite literally means stasis is to stop, Hemo means blood. So literally the process of hemostasis involves these 3 steps. Vasoconstriction is the first of those steps where blood vessels are going to clamp down and reduce the blood flow. So they literally start to spasm. Blood vessels undergo venous spasm or vasoconstriction, reducing the flow through essentially a leaking blood vessel or a bleeding blood vessel. Then we're going to activate the process of clotting. And clotting is activated by platelets. These are the cells in your blood called thrombocytes or platelets. And then these platelets, so let's assume that these are some platelets that have clumped together. These platelets, once they clump together and they form essentially a plug at the site where we're bleeding, this is referred to as a clot. Then the last step in this puzzle is that we're going to now coagulate. And with coagulation, this is where our proteins that are made in the liver floating around in your blood as liquid proteins, you know of them as factor 10, you know of them as prothrombin, and you know of them as fibrinogen. They all activate each other to form little strands of string called fibrin. And that fibrin wraps itself around the clot. The process of coagulation forms this yellow stringy fibrin. It wraps itself around the clot. And once it's wrapped itself around the clot is now called a thrombus. So when we talk about, well, what's the difference between a clot and a thrombus? A clot is the clumping of the cells, and thrombus is the clumping of the cells that have now been wrapped up in little stringy strands of fibrin. And that process, that occurs through coagulation. Now remember, as a person becomes coagulopathic, they're becoming coagulopathic because they're losing their clotting function, they're losing their platelets, but they're also losing this factor 10 and their prothrombin and fibrinogen and the other factors that are important in the coagulation path. Here's a better picture than what I could have drawn. I forgot that this image was here. So here's a beautiful picture of a fibrin mesh wrapping red blood cells, and these tiny little purple dots that you can see, they're platelets. They're about 1/4, a quarter the size of a red blood cell. You can fit usually 3 to 4 platelets inside a red blood cell, just to give you a bit of a perspective of time. Okay, we've talked about consumptive and dilutional coagulation. So as you can imagine, if all of your coagulation proteins are sitting here in your plasma and all of your clotting cells, your platelets are sitting here in your cellular material, and I was to lose some blood, I'm going to be losing both clotting and coagulation material. I'm going to drop my blood volume, and if I prop that blood volume up with just water, you can see how I've diluted both. So I've made that patient coagulopathic simply by diluting them. Okay. That hemodilution is one of our major contributing factors to coagulopathy. Okay. So the patient bleeds, they form a thrombus. The inflammation process activates a protein called protein C, which then starts to inhibit the clot formation. Your body doesn't like to have clots clogging up blood vessels, so it activates a fibrinolytic pathway. Now, this is a substance in your blood called plasminogen. I'm going to write that word down because it becomes important in a sec. Plasminogen. And what plasminogen does is it's floating along inside your blood right now looking for fibrin. It's looking for that stringy material that we saw on that previous slide back here. This stringy white cottony sort of looking material is called fibrin that forms from the coagulation pathway, the process that we simply refer to as coagulation. Now, what this plasminogen is going to do is it's going to be hunting. It's a precursor enzyme, and it's in your blood right now, and it's hunting for blockages. Remember, your body should have unobstructed blood flow around blood vessels. So every time there is a trigger that causes you to develop or form a clot, particularly if that clot is wrapped up in fibrin, then this plasminogen is going to activate. And when it activates, it loses the ogen on the end of its word, and it becomes this substance here called plasmin, which is an enzyme that chops up the fibrin. So your plasminogen activates to plasmin, it starts cutting up and breaking up the clot so that you can improve blood flow. Now, this process, unfortunately, is happening at the same time as a trauma patient is trying their hardest to bleed to death. So they're trying to bleed, they're trying to clot to stop the bleeding, but this plasminogen is also at the same time trying to break down the clots as fast as they're made. Wouldn't it be really cool if we had a substance that could block this process? Wouldn't it be great if we could switch off this plasmin and just let the patient clot so they don't bleed to death on us? And that's where that medication TXA comes into play. Tranexamic acid is used within the first 3 hours of a bleeding trauma patient, specifically to disable the plasminogen proteins that are in your blood so that you don't break down the clots that you're busy trying to make so you don't bleed to death. I'm hoping that kind of backhanded response makes sense. But before we give that patient tranexamic acid or TXA, can you see this process further fuels their coagulation problems? They've got ever so increasing levels of consumptive coagulopathy. They're breaking down their clots. They're releasing and activating their plasminogen, and all of this plasmin's preventing newer clots from forming. This patient continues to bleed. They're trying to clot, but they can't stop bleeding, and they continue to bleed. It makes it notoriously difficult for us to be able to provide hemostasis to somebody when they've got all of their plasminogen that's been activated. So we can shut that process down by using tranexamic acid. And indeed, we certainly try to do that. Now the fourth player, and I know that we're about an hour into our session. We've got about an hour to go. If you're watching the recorded version of this, now is probably a good time to put it on pause and grab yourself a coffee and come back to it. For those that are sitting live, we've got about an hour to go almost. So we're around about that halfway period. Let's talk about the fourth player, the sort of the new player, the new kid on the block as our fourth dark horse of this trauma triad that's now referred to as the diamond of death. And that's calcium. Now, right now in your blood, you've got calcium that's floating around inside your plasma. And within your plasma, you have a number of proteins. We've just talked about coagulation proteins, and we've talked about plasminogen. That's another protein that's in your blood. But one of the dominant proteins that's in your blood is a protein called albumin. And albumin binds itself to calcium in your blood. And what causes it to bind tighter to calcium in your blood is alkalosis. So acidosis causes the calcium that's bound to or stuck to the protein molecules in your blood to be released. So as my patient becomes acidotic, all of the protein holding calcium molecules that are in the blood are freed, they're released, and they become what's referred to as ionized calcium. So my patient is bleeding, they're becoming acidotic. As they're bleeding and coagulation requires the consumption of calcium. So they're using up calcium to try and make clots to stop their bleeding. They're becoming acidotic, which frees up more calcium that they're using or consuming. Can you see that calcium levels are dropping? Now, if we couple that with certain types of trauma, particularly large electrocutions or patients that have had severe crush injury, when muscle is crushed, when somebody undergoes a crush injury, crushed muscle releases a very large amount of an electrolyte called phosphate. PO4 is phosphate into the bloodstream. And what phosphate does is it goes in hunt of something to bind to. And phosphate loves to bind to calcium. It forms concretions called calcium phosphate in the bloodstream. And once that phosphate has bound with the calcium that's in that patient's blood, as a result of releasing a large amount of phosphate from crushed muscle or crushed tissue, that phosphate binds with the calcium in their blood, then that removes the calcium from the bloodstream to be available for the patient to have normal calcium levels to do coagulation and muscle movement and cardiac strength, all of the reasons that we need calcium in our blood. So crush injuries will reduce somebody's calcium dramatically because of that phosphate release binding and acting like a sponge and soaking up all the calcium, making it not available to any other tissue. So that's kind of a bit of a picture of our early hypocalcemia. Why does somebody have a drop in calcium early in trauma? Early in trauma, they're losing calcium because they're bleeding. You lose blood, you lose calcium. Early in trauma, particularly with crush injuries, that phosphate will bind with the calcium that's in your blood. Early in trauma, you're becoming acidotic. And because you're acidotic, you freely release all of that calcium from albumin. It's released into the blood and then immediately gets consumed. And early in trauma, while you're bleeding, you're trying to coagulate, and coagulation requires calcium at almost every step. So I can't convert factor 10 to 10A without calcium being present. I can't turn prothrombin to thrombin without calcium being present. I can't make my fibrinogen turn into fibrin, those little strands of string, without calcium being present. So you can see that if I'm in the process of coagulating, I'm in the process of using up my calcium. So now we've got this patient who's lost a large amount of blood. And typically, what are we going to do for someone who's lost a large amount of blood? We're going to transfuse them. Makes sense. This person's lost a large amount of blood. Let's transfuse them. So we go down to the blood bank, we grab a bag of blood, and what we notice when we grab that bag of blood is that that blood is in a plastic bag and it's liquid. And if you've ever bled anywhere, on the floor, onto a towel, onto a bed, if you've ever bled, you've seen that within seconds to minutes, your blood turns into a gelatinaceous clot sitting there on the bench or sitting there on the bed. Blood congeals and coagulates. It does that both inside the body, but it also does that outside the body. So why is it that the blood that's in the blood bank bag that we're going to now use to transfuse to a patient, why is that liquid? Why didn't that clot? And the reason is because they put an anticoagulant in it called sodium citrate. Sodium citrate is in the bag, and that's what keeps that packed red blood cells liquid so that we can transfuse it. So now I'm going to give them a bag of blood, or 2 bags of blood, or 3 or 4 or 10 if we're on a massive transfusion protocol. I'm replacing blood into this patient, but a sizable portion or a definable portion of that blood that I'm giving to the patient has citrate in it. And what citrate does is it immediately binds to calcium when it gets into the patient's bloodstream and soaks up all their calcium. So you can see by transfusing a patient with large amounts of blood, then what I'm doing is I'm further reducing the calcium in their bloodstream. So massive transfusion protocols must always be considering that at the same time as we're giving blood, we should be also giving calcium, a dose of calcium up very, very early in our trauma patient has been a complete game changer. So I hope tracking through these 4 big life threats of hypothermia, acidosis, and coagulopathy, and of course hypocalcemia, that has helped to provide a bit of a rounded understanding of where our big life threats are. Over and above airway, breathing, circulation, and loss of consciousness, it's these 4 dark horses that become a major concern. Okay. So I'm going to pause there just for a minute and see if there's any questions to this point before we go on to some epidemiology. Has anyone got any questions to this point, talking about the dark horses of the apocalypse? Or clarification? You might need some time to synthesize that. It's a lot. Alrighty, let's push on. Let's have a talk about epidemiology, completely change gear, and talk about what is it that causes trauma. Well, we know that the main vector that causes trauma in an older person is going to be falls. In fact, it is the leading cause of injury. Statistically, the leading cause of death from injury is a fall. Motor vehicle crashes are the highest percentage of severe injuries and a collision with a person or an object. So pedestrian versus car, as an example, are included in those stats. Suicide, sadly, is the leading cause of traumatic death in the 15 to 45 age group. So what are the factors? Well, certainly age is a factor, gender, violence, alcohol, tobacco, and other drugs. Occupation can be a factor when you think about some people just have really dangerous jobs. So statistically, there's going to be a higher incidence of injury, perhaps. Rurality. We certainly know that there is an increase in mortality the further away you are from a tertiary referral centre, and things like animal strike. Now, this is not an Australian photo, it's a photo from Canada. It's an interesting image that was sent to me by an uncle of mine, and this image is called "The Moose Goes In," and this image is called "The Moose Comes Out." The sad reality is, whilst yes, the moose was killed during this incident, so was the driver of the car, a young 19-year-old girl. Age is a factor in trauma. When we have a look at the breakdown of the different age groups within pediatric traumatic deaths, in the 1 to 14 year age group, it's transport trauma. Now, I need to make it very, very clear that these pediatric age-related deaths, these are Australian statistics. If we were talking about America, the leading cause of pediatric death in America is gunshots. So gunshot injury is the leading cause of death in the United States. In Australia, we just don't see gunshots. Very rarely. We might see 1 or 2 gunshots deaths a year. So in that 1 to 14 year age group, transport trauma is the highest cause of traumatic death. In the 15 to 44 age group, of course, that bracket, we're looking at suicide and transport trauma, motor vehicle crashes, assaults, and in elderly patients about over the age of 65 specifically, these stats are taken from, falls are the leading cause of death. When we have a look at the gender, or probably that term should be the sex of a patient, men make up 65 to 70% of all injuries. And statistically, men have more lethal injuries. There's a 300% higher mortality rate in men from trauma than what there is in women. Young males, 25 years and under, make up 30% of the total trauma deaths in this country. Suicide rates are disproportionately spread between men and women, about 3 to 1. So for every 3 suicides in men, 1 in women. Suicide in men is often of a more violent nature than in women. When we talk about race and the disparity of race as an epidemiological factor in trauma in this country, Indigenous death rates are about 3 to 5% higher on average annually. There's a 3 times increase in motor vehicle death rate in Indigenous Australians than what there are in non-Indigenous. Non-intentional poisoning continues to be rife in many communities. And it's just the poison that changes. So where a few years ago it was petroleum products, and in the last decade there's been a movement away from chroming and volatile inhalants to now things like sly grogging and methamphetamine, which arguably have always been there. Alcohol and drug use is, of course, linked to trauma and traumatic death. It's linked to accidents, particularly with motor vehicle crash. Driving under the influence of alcohol is annually on the increase by approximately 3 to 5%, despite campaigns like random breath testing. In a recent survey that was done by our local police force here in Queensland, 9 out of every 1,000 drivers were in excess of the blood alcohol limit, the legal blood alcohol limit, on random breath testing. Ethanol violence is double that of all other drugs. So whilst we often hear stories about drug-related violence, particularly fueled with psychostimulants like methamphetamine, ethanol still trumps those. It's double that of all other drugs combined. Drink violence has decreased over recent years with the introduction of using plastic and lockouts in bars and last drink calls. However, we still see quite a lot of in-home drink violence. Certain types of occupations and sports are certainly dangerous. I had the pleasure and the sheer enjoyment of working in an outback town called Quilpie, where a lot of rural towns engage in this very, very dangerous sport called polo cross. And boy, some of the injuries that we saw from that were phenomenal. I've never seen bones coming out of places where bones just shouldn't come out as a result of the clashes of two horses and one human being caught in the middle of in a high-speed game of polo cross. Now, remember, as Kath and Kim would say, we have to look at MOI, and this is the MOI, the mechanism of injury. Remember, all injuries are caused by a transfer of energy, and the transfer of energy is our vector. If we can understand the mechanism of injury, it helps us to have a deeper understanding as to perhaps what kind of trauma we might expect when we start to do our assessment. So remember, energy is the capacity to do work. Energy can't be transferred. It's moved from, it can't be destroyed. It can only be transferred, is what I can say. So it's transmitted or transferred from the implements that's providing the energy through to the tissue itself. So there's a number of different types of energy, and by far in trauma, the most common is going to be mechanical or kinetic energy. This is the energy of movement. So when we think about the energy of movement, we think about acceleration injury, deceleration injury. We think of the movement of a projectile or a missile type implement going into tissue, so gunshot wounds. We think of stabbing type injuries. We think of blast injuries, and we think of assaults. So some examples, certainly when we think of patients with an acceleration injury, this is when the body in a stationary position is suddenly launched into an acceleration or suddenly moved forward. Think of a patient who's received a rear ender. They're sitting at the lights, minding their own business, checking their Facebook feed, and somebody drives into the back of them without warning. T-bone type injuries or rear ender type injuries are classic examples of a acceleration type injury. When we have a look at a deceleration injury, this is also referred to as drag, and drag is the force that stops a moving object. I hope you aren't offended by my use of this image from perhaps one of my favorite films of all time, which is Priscilla, Queen of the Desert, which was a movie about drag, different sort of drag. So it's a force that stops a moving object, and I think you'd probably argue that if these guys walked into your local shopping centre, particularly in a more conservative part of Australia, that's probably going to stop everything, isn't it? Falls are an example of a deceleration type injury. The inertia of various tissues within the body. And we look at a number of different tissues. The duodenum is a classic example. In days gone past, when people would wear a lap belt, so the seat belt in the middle seat of the back seat of an old car from the 1980s and the 1970s, it didn't have the lap sash coming over the shoulder like the two seats on the outside. The seat in the middle just had a single little lap belt that went across, and lap belt complex would be something that we would see quite commonly, particularly in children from a deceleration injury, as that lap belt held their body in the car, but that extreme bending over caused quite a large perforation or damage to the duodenum. In deceleration injuries, where the body suddenly comes to a sudden halt or a sudden stop from high speed to a sudden stop. So think of a vehicle traveling at 100 or plus kilometers an hour, suddenly hitting a tree or coming into a solid object. Then certain tissues within the body continue to move forward with inertia, but other tissues may be relatively fixed. And one such example is the descending aorta. So where your aorta comes out of your heart and it bends over in that aortic arch, it then runs down behind your heart. It's somewhat tethered at the back with a little ligament that was at one point in time the remnant of your ductus arteriosus, the hole between your left and right heart that you had when you were in utero. Remember, you don't remember it, but you were born, you took that first one or two breaths of life, and that little hole that flap between your left and your right atria closed over, and it became a ligament called the ligamentum arteriosum, and it attaches to the descending aorta. It's a relatively fixed attachment. So in extreme deceleration type injuries, then that loop of the aorta can fly forward, can keep going at 100 k's an hour when the rest of the body has stopped, and literally rip the aorta through at that ligament. And this is a descending aortic rupture. It's often associated with an immediate exsanguination. These people are going to bleed to the tune of 900 mils a minute. They're often found dead on arrival. Object inertia, as the name implies, is the inertia of objects that are unfixed within the car. And we've all done it. We've all jumped in our car and gone for a drive and suddenly had to put our brakes on, and everything that was sitting on the passenger seat, our phone and our wallet and our handbag and our drink bottle and everything flew forward. That object inertia can certainly cause injuries. And I've had the misfortune of having to attend a roadside crash where one such object inertia actually caused the loss of life of the driver, as a large can of dog food from the grocery shopping launched itself off the back seat and straight into the back of this woman's head, causing a very, very high spinal cord injury that was incompatible with. Head-on collisions are an example of a deceleration type injury. Now, we're not going to go into any great detail on bullet wounds. If that's particularly a little wormhole that you want to go down, then by all means use this as a link to, or a little memory jogger to go and look up the kinematics of gunshot trauma. But the simplest way for me to sort of unpack this image for you is to recognize that the amount of damage that's done to a body, the amount of energy that's transmitted to the body, and that's kinetic energy, is influenced by not just the size of a bullet, but also by the speed that the bullet's traveling. I'd like you to consider that I had a bullet that was 5 grams and a stone that I'd picked up off the ground that was also 5 grams. So both of these projectiles weigh exactly the same and are probably roughly the same size. If I shot one at you versus throwing one at you, obviously the one that I've shot at you at a much, much higher speed or a much higher velocity is going to cause more damage. So it's not necessarily always the size of the projectile that causes the trauma, but the speed or the velocity of it. And that's what this little equation means. The kinetic energy equals 1/2 multiplied by the mass, which is the weight of the bullet, times the square of its velocity. In other words, its speed squared. Now, once we calculate those numbers, then we can certainly see that the most dominant of those two factors is not the weight of a bullet or the caliber of a bullet, but it's actually going to be the speed from the implement that it was shot. So a 22 that's been shot at you from, say, a low-speed handgun versus a 22 that's shot from a high-speed hunting rifle, that same bullet is going to do far more damage if it's coming from a high-velocity weapon. Gunshot injuries are an interesting thing because they do not follow the standard rules of trajectory. Whilst the bullet hits, or the projectile hits the torso of somebody, its movement through that patient is often influenced by it hitting things like bone and muscle as it ricochets and bounces through. Many projectiles are designed specifically to fragment or to mushroom when they hit a solid object, and this causes maximum damage. Remember, these weapons are not designed to hurt people, they're designed to kill. So maximum injury is going to occur as a part of their engineering. What you see here is a patient who has a gunshot injury with a shotgun and has sustained a hemothorax, a hemopneumothorax, and has been treated, obviously, in an intensive care unit, and the patient's being treated with a chest drain in, and about to be prepped to go to theatre to have that abdomen opened up to see really what the carnage is, what we're dealing with. Blast type injuries or explosion type injuries can certainly cause injury to tissue, and this is the example of a child who did not throw an explosive device away. Sadly, in places all around the world, particularly up in Indochina, there are villages and farmers that are still finding, and fishermen that are still finding implements that were unexploded ordnances from from the conflicts during Vietnam and the Korean Wars, and they're still finding these things, and unfortunately succumb to nasty injuries. In Australia, we tend to be not so lucky. We don't have as many landmines, and we don't have as many explosive devices, but things like homemade firecrackers and homemade explosives that sometimes kids and teenagers like to experiment with can certainly from time to time enter into the literature and absolutely enter into our emergency departments. And we see sorts of injuries like this. Blunt force trauma and penetrating trauma, of course, are all going to cause injury to tissue. This is a perfect example of a penetrating trauma into the front of this patient's neck. Point of call here, please don't ever take the cutlery out of somebody. It's not your role. It's above your pay grade. Okay, there's always somebody else that's going to remove the cutlery. So please don't complete the injury. If we're trying to figure out where we're going to start with this, perhaps airway, breathing, circulation, and level of consciousness is the best place to start. But ultimately, what we want to do with an injury like this is to stabilize it. We'd want to use some sort of a tape to be able to make sure that it can't wriggle and it can't just fall out. We don't want this patient to exsanguinate in front of us. So let's talk about chemical energy. Of course, when you think chemical energy causing harm or causing injury, then you're thinking of the classic rock stars of acids and petrochemicals and venoms and chemical energy that we might get from drugs. So let's have a look at some examples. This is swimming pool acid. It's the hydrochloric acid that people every weekend will pour a litre or so into their family swimming pool to buffer the pH of their pool. It's excellent inside swimming pools. It gives you beautiful crystal clear water, but it's not so good when it's sprinkled on your child's foot when their foot was only being protected by sandals. And so you can certainly see the chemical injury that has occurred here from this acidic burn. This is the result of a snake bite. This is an American image. It's come from a snake bite, one of the rattlesnake species in America. The patient was bitten on the upper arm, so they were bitten just underneath the bicep, sort of between the bicep and the tricep, on their upper arm. And it's caused such profound swelling that what you're actually looking at here is necrosis as a result of essentially a compartments type syndrome. So this is a person that's got quite a large amount of necrosis there. And if you look really careful in the center of this patient's hand, you can see how black and necrotic and how in need of debridement this hand's going to be. Multiple skin and muscle flap repairs, and this patient actually made quite a sensational recovery and were able to keep function of all of her fingers. The lacerations that you can see in this image, you can see two across the palm itself, one across the heel of the thumb, and then another laceration that runs up the center of the forearm of this patient. These are referred to as fasciotomies, and they were performed when the swelling got so great that the circulation was compromised. They have literally split the skin surgically to be able to allow the swelling to open up like a sausage on a barbecue, essentially. You know, when you split a sausage on a barbecue and it just opens out. Well, the same sort of process can happen with profound swelling from chemical type injuries like certain snake bites. We're lucky in Australia that we don't have very many snakes that actually cause a tissue trauma like this. But if it starts with T, there is a potential. So tiger snakes and taipans cause tissue trauma and pain. Electrical energy, certainly if you've ever been electrocuted and were unlucky enough to have been burned, you would have seen that transmission of electrical energy can certainly be transmitted through to thermal energy and cause burns. This is a patient's knee, and I know it kind of looks like a bit of an awkward anatomic diagram, but we're looking at the top of the patient's leg here. This is the crease of their knee. So you'd be looking at the patella would be sitting up here somewhere. So this is the femur and then down to the lower leg. So you get a bit of a perspective of this image. This person came into contact with high voltage electrical cable, and you can see that there is a burn mark in two locations. Not really sure which one was the entrance point and which one was the exit point. It doesn't matter. You can be convinced that there is actually a burn that runs between those 2 points. So as much as you might see the burn on the outside of the patient's skin, make no mistake, they are burned all the way through that muscle in that deep fascia. Electricity tends to follow the path of least resistance. So with high voltage electrical injuries, then it's not uncommon to see significant muscle injury, rhabdomyolysis, take place as a result of an electrical incident. This is something that very few of you will ever see. These are called Lichtenberg figures or Lichtenberg flowers. They're quite an interesting sort of almost looks like a tattoo, but these are caused when somebody is struck by lightning. The typical burn that we would get from an electrical storm where a person is physically struck by lightning is going to cause a flashover type burn, and often the patient will be left with this sort of scarring permanently. It's not uncommon that this person will have a story to tell for the rest of their days. This man, being alive to tell the tale and to show his scars off to the boys at the pub, would represent approximately 10% of people, sorry, 90% of people who were struck by lightning. Only about 10% of those that are struck by lightning are killed from it. Interestingly, it flashes at the outside of the body, often preserving life. Radiation type injury. Well, we think of radiation as being like a Chernobyl type incident, and certainly that certainly would have caused burns, that exposure to that gamma radiation. But of course, we're also talking about UV radiation, and this is perhaps the most common radiation injury trauma that we actually see. This is a young lady who should have been watching those ads on the TV for slip, slop, slap. We see quite a lot of this in my theatre of practice. So I actually work in a recompression chamber, a hyperbaric unit, and we have many patients who come into us for non-healing wounds after radiotherapy. So this patient's had radiotherapy for a head neck cancer, and you can see the breakdown of the skin as a result of that X-ray therapy or that radiation therapy that they've had for their cancer treatment. Sadly, radiation therapy is not without its costs and benefits. And of course, the costs, one of those costs is we can have really problematic, very, very difficult to heal wounds after radiation therapy. And hyperbaric oxygen is one of the strategies that we use to help heal this tissue. And the last of our energy vectors is thermal energy. And these are quite confronting, these images. And when we do our burn session, I really will remind everybody when the burn session's coming up to make sure that you don't have any, children or non-medical people wandering around, because the images in the burns lecture that I'm going to be bringing you are quite confronting. This is a young lady that was dragged out of a caravan fire, and she's received circumferential burns across her entire chest. She was also quite severely burned on her back and succumbed to her injuries, unfortunately. The quickest way that these patients will die with circumferential burns around their chest is as these burns start to tighten and the skin takes on the appearance of eschar, like leather. It's inelastic. They physically suffocate. They cannot breathe. It's like having a tight band around their chest. So a surgical approach very, very early on, a trauma surgeon will split the patient's skin literally so that that skin can be disconnected from the rest of the chest wall to allow us to adequately ventilate the patient. We physically can't bag these patients when they're circumferentially burned. The swelling reduces that dramatically. And folks, I wasn't sure that I was going to be able to do it, but I managed to do it. Look at that. We're an hour and a half in, and we've come to our end slide. So we've really looked at quite a bit in the last hour and a half. What the session has done is it's introduced us to what trauma is. We've looked at a little bit of epidemiology on trauma. We've investigated the vectors that cause trauma, which is energy. We've looked at kinetic energy or energy of movement. We've looked at chemical and electrical and radiation, and of course, thermal energy, burns. And we've had a look at some of that cellular biology, and we've taken a little bit of a deep dive into the four dark horses of the trauma room, which is our acidosis, our hypothermia, our drop in body temperature, our coagulopathy, and of course, our newer kid on the block, which is a drop in calcium, our hypocalcemia. I hope that's given you a little bit of something to sort of whet your appetite for what's to come. In our next week session, what we're going to do is we're going to be looking at primary and secondary assessment. Following on from that, we'll do shock, and then we're going to start through each of the body systems as we go through to the end of our series. From this point of view, I'm going to stop the recording now, and please feel free to drop me emails for any questions that you have. For those that are currently online and waiting to ask me questions, just hold your microphones for a second. I'll just stop the recording and I'll be right with you in just a moment. Thanks for watching, folks, and I'll see you in the next episode of Trauma Fundamentals. Thanks, team.